be a precursor of CSC, or it can be an outcome of resolved CSC, and it can evolve into further pachychoroid neovasculopathy or PCV. So in this case, you see that in the first picture, you see that there is pachy vessels, and although there is no presence of SRF, there is only RP changes. But further, it can lead to there is presence of subretinal fluid, and it can be a precursor of CSCR. In this picture, you see there is presence of RP changes, pachy vessel, subretinal fluid, and later you see that the subretinal fluid gets resolved, and only the RP changes and pachy vessels are seen. So PP can be when the SRF gets resolved, it can look like PP also. In CSCR, there is diffuse or focal pachychoroid features along with serous PEDs, and SRF appearing is ill-defined circular ovum dome-shaped elevation of neurosensory retina, and it occurs when the RP pump mechanism gets overwhelmed by increased choroidal permeability. So CSCR, again, it is serous detachment of neurosensory retina. It can be acute or chronic, and it is often associated with one or more serous PEDs. So when do you suspect CNVM in a case of CSCR? When there is presence of persistent subretinal fluid, there is presence of pachy vessels, increased choroidal thickness, there is compression of choriocapillaries, loss of RP layer, and double layer sign. So what is basically double layer sign? So you see that if it is hyperreflective DLS, so it is a indication of there can be neovascularization. If it is only hyporeflective DLS, it can be seen in CSCR only. In pachychoroid neovasculopathy, again there is all the pachychoroid features associated with RPE alterations and subretinal fluid, and there is associated type 1 neovascularization and hyperreflective double layer sign is there. So this is the pachy vessels. You can see overlying the there's double layer sign, there is presence of subretinal fluid. Again in this picture you see that there is presence of subretinal fluid, there is hyperreflective double layer sign, and although there is no neovascularization is seen in this picture, although in this octa you see there is presence of neovascularization, so it can be pachychoroid neovasculopathy. So how do you differentiate pachychoroid neovasculopathy from neovascular AMD? It is usually present in younger age group. There is no associated drusense, no or minimal exudation, no or minimal hemorrhage. All the pachychoroid features are there, and it is usually slower involving. Coming on to PCV, it is primarily a disease of choroid, and it is associated with serous exudation and hemorrhage that may lead to detachment of RP and sometimes neurosensory retina. So it can be of exudative type, hemorrhagic type, or mixed type. So definitive diagnosis is by ICG. You see multifocal choroidal hyperfluorescence, polypoidal vascular dilation, and presence of branching vascular network. So on OCT, how do you diagnose the PCV features? In this picture you see there is multilobulated or notch PED in the left picture. In the middle picture you see there is sharp peak PED where the angle is 70 to 90 degree. And in the third picture you see that there is hyperreflective ring underneath the PED. So again, this is sharp peak PED, this is thumb-like PED, and here you see that there is a presence of hyperreflective ring along with hyporeflective lumen, which is indicative of polyp on OCT. So this is a picture, you see that multilobulate PED is there, and status post anti-VEGF, although the PED has resolved, there is still presence of BVN on octa. So there is another term called focal choroidal excavation. It is a structural abnormality with unknown etiology consistent with localized concavity in the choroid occurring without posterior staphyloma, and it can be associated with type 1 or type 2 CNVM. In peripapillary pachychoroid syndrome, there is usually presence of characteristic abnormality same as pachychoroid spectrum is there. The nasal choroidal thickness is more than temporal choroidal thickness, and the nasal IRF or SRF is there, and occasional disc edema. So to conclude, pachychoroid is spectrum of disease which needs to be recognized early and at correct stage. In patients with CSCR with persistent SRF, you should suspect of CNVM. Multimodal imaging is helpful in this, like enhanced depth imaging, OCT, octa, and ICG, and understanding the mimickers and OCT biomarkers is necessary. Thank you.
I think very good presentation, covered almost all aspects, which is difficult. I think there could be a lot of discussion. Maybe we can have, if there is any. Yeah.
I wanted to ask the panel, so what is the application of pachychoroid disease in the real world? I mean, how do we treat this patient differently and how do we counsel such patients differently from a normal choroid?
I think more from whatever we learn at this time and whatever we have understood, most of the time you will not be treating because I think it is like, as she mentioned, it is whole spectrum and we go through the various stages. Even pachychoroid neovasculopathy, you may not treat it, but you observe it. So that's where I think the biggest confusion, at least I have had, and I have asked many people, is about this double layer sign, because this is present in everything, everywhere. And the situation is more complicated once you have already given multiple injections. It will persist. So I think what we, at least I have learned, no, don't concentrate on that. Don't try to kind of collapse that. Let it be until unless there is a fluid. So I think it creates many a time situation for us. That is something which I thought I would mention.
Other thing, I think Octa sometimes will be helpful. I don't know how many of us has access to ICGA, but
Yeah,
Octa
I
is
think
becoming a little more
the problem
frequent.
is most of the time you may not pick all the time these polyps. That's a problem. You may also pick up VVN, but then the question is we are not treating these. Now there is a question that, and we have enough data, many studies, that even if you are observing all these, even if there is a frank neovascularization and there's no leakage, you're just observing it. So that part is clear at this time. At least that part is not something which should be confusing. So is all these tall, big PEDs, it may be huge. Now there's a big study where we may do more harm and it may rupture and you may create more issues until unless it has really gone into that stage which is start leaking. Even that fluid on the top is not. It is not because it's because the photoreceptor are getting there. So I think many things we have to learn. So that is what is happening. Thank you. I think we'll